Hello, my name is Christian Verender. I am a GP and I am the clinical lead for MSK commissioning.
I'm Martin Longley. I'm also a GP and I sit as the primary care rep on the MSK board.
So the purpose of this video is in a short period of time to hopefully explain the new low back and radicular pain pathway that we have adopted as an entire system through Dorset. We have been slowly but surely getting this out to GP practices through a pilot phase, which Martin has been involved with. But hopefully this will help you manage your patients with low back pain and with sciatica better. Martin, you've been involved in at the coalface of this in the pilot phase. How have you found things?
So the benefits of our practice piloting the start back piece of this pathway was it gave us a structure for managing low back pain. It allowed us to risk stratify the patients into three groups, which we'll talk you through much later in the video, and allowed the patient to get appropriate early intervention where necessary by the right person in the right place, and that right person was usually the physiotherapist. The interesting statistic we have at the moment is that 100% of these patients that have been referred to start back have not represented to primary care with their low back pain, and there's very high patient satisfaction ratings for the treatment they've had.
So hopefully as we roll this out, your own practices can benefit from a similar experience to Martin's, and what we're going to do is take you through the resources that are out there, and then ultimately the System 1 template that we've devised to help you deliver this. One of the things we originally did when we looked at the whole spinal pathway was to adopt the National Low Back and Radicular Pain Pathway as a community. Now this diagram is our best representation of that whole pathway, which is very complicated. We've managed to try and summarize it on a page. The things to note here is that it's in two sections. We have the left that's in green, that's the low back pain, and the right, or in red, which is the radicular pain. And it's really just to introduce the concept that these are fairly separate conditions. They just happen to be treated by the same people, both in primary care and community and secondary care. We will be concentrating on the top half of the pathway in terms of self-management, red flags, and then primary care management. Martin will talk a little bit about start back and then the referral pathways from there, and I will talk a little bit more about radicular pain and the primary care management of that. But this can also show you and your patients that there is a thorough system beneath and beyond referral that involves investigation, imaging, injections, more combined and physical psychological therapy, and then multidisciplinary assessments before anyone goes back in and around the system or onward referral.
The next two slides deal with mechanical low back pain. That is obviously pain where there is no radicular features. Low back pain is a common presentation to primary care, and the goal of the spinal pathway is to demedicalize low back pain. There is a primary care screening tool which has been developed by Keele University, which is the subject of the next slide. There will be early access to specialist physiotherapy and psychology practitioners depending on the outcome of this screening tool. We have developed a group of standardized patient leaflets which again will be available from the spinal care dashboard. The goals of the message for musculoskeletal low back pain is to keep active and to maintain activity, is to keep working or return to work, to avoid bed rest, and to use the simple analgesic template, which again is added later in this slide. If the patient has muscular low back pain with no radiculopathy, you will be directed to the Start Back screening tool developed by Keele University. This screening tool has 9 simple questions for the patient to answer, either agreeing or disagreeing, while the last question which asks them to rate their pain. Once these questions are answered, the tool generates a score which will put the patient into one of 3 groups, either low risk, where they will be encouraged to self-manage, or medium or high risk, where they will be referred directly on to specialist physiotherapy practitioners. The template will immediately direct you to a physiotherapy referral form if they fall into the medium or high risk category. This will self-populate all the patient data as well as the Start Back screening data and allow an area for further explanation of the patient's pain. These patients will be seen very quickly by a specialist physiotherapy, and we're anticipating that they will be assessed within 2 weeks.
A significant proportion of the patients screened through Start Back will fall into the self-management category. The following slide shows the essential messages these patients need to take home to potentiate their recovery. The tool will also lead you to self-help leaflets, which again will reinforce the message of keeping active and continuing to follow their normal lifestyle.
So radicular pain is a little bit more complicated, as is the condition, and I'm not going to tell you that patients and this condition always conveniently fit into nice stratified boxes, but that's what we've done here is try to give a structure and approach to enable us to mentally stratify patients into a low, medium or high risk group, as that will then determine our action with the patient in terms of referral or managing them in primary care. This second sheet is hopefully giving us some helpful references to base our risk stratification on, and these include a definition of what a hard neurological sign would be, a reminder of muscle power grading, because I don't think many people can remember it, and we normally just put people into weak or normal. Hopefully a helpful little aid memoir on the myotomes and dermatomes and reflexes related to the spinal segment, and then some references on a holistic approach to how we would stratify symptom severity. Now, this side talks a little bit about exceptions and red flags, which you will all be very familiar with, and then we try to stratify patients to low, medium, and high risk depending on how long it's been going on for, the severity of the symptoms, which would refer to these sort of boxes over here, whether they have any hard neurological signs. Again, this would then inform us over here, and then a softer emotional impact scale. And we've got 0 weeks, 6 weeks, and 12 weeks here as a representation as to time frames. And if we think a patient is fitting into a low risk category, that should give us confidence to then manage these patients in primary care. Now let's be clear, what can we do in primary care? We can watch and wait, we can monitor, we can reassure patients, we can give out patient information and guidance on activity, we can prescribe along with nice guidance, we can refer to physio, and we can refer on to for further investigation. And it's the low risk that we want to hang on to in primary care, because we know a lot of these patients will get better within this sort of 6 to 12 week period. In the medium risk, Again, they have no hard neurology, but their symptoms are more moderate. And these we think would probably benefit from the additional input from physiotherapy over this hopefully self-resolving time period. And then there's the high risk, and that's to do with the severity of the symptoms, the duration to a degree if it's going on beyond the 6 weeks, but also the presence of any hard signs. And obviously that wouldn't require them to be present for over 6 weeks before referral. And that is what we're suggesting would then should trigger referral on to a further assessment in the triage and treat service, as investigation may then direct their management better. I think what's key to remind us is that, and what we all do, is to reassess, as patients can obviously move from low risk to medium risk or even to high risk if they start developing hard signs, and we should be ready for that. There will be a link in the System 1 dashboard to prescribing guidance as well. Here we have the patient handout that we would encourage you to print and will be linked to within the dashboard. This one is for sciatica, and it is different from the low back pain information sheet that we've developed. It talks about the condition and the key facts and quotes the healing timescales and refers to that 6 to 12 weeks or 3-month window where things tend to improve. Talks a bit about the assessment and how we diagnose things clinically, treatments, physio, and some other things that may happen later on in the pathway. Some do's and don'ts, and then some basic simple exercises that they can get on with. Okay, so this is the last section, and just a quick look at the System 1 template that we have devised to hopefully make this easier to use and to access the pathways. So we've got here a test patient. Before I jump into the template, I was just going to show you the Ardens templates. So on Ardens, there is a start back scoring tool that is available to use, which is helpful. We are talking to Ardens and hoping to get a box in around here or somewhere that is a link to our dashboard as well to make it accessible. But obviously it will be able to download the template, and you can put it in your tree over here, or you can put it into your these A to Zs or your favorites as you like. Everyone seems to have different preferences from that point of view. So if I just search on it, it's the Dorset Spinal Pathway dashboard. It's in draft form at the moment, but it will be available. So this is the landing page, which basically just navigates you to all these different tabs along the top. We've put in the go-to documents on this front page as well, which is the sciatica self-management link, ready to hopefully print off when you're with a patient. And that's you've seen that in the previous presentations, and similarly the low back pain sheet. And you'll find links to these in the tabs as well under the same color. So as we move through the radicular pathway, this basically has makes it easy to record the things that you need, and some helpful diagrams just to remind us when we're in a consultation. We've also got the links to the physiotherapy referrals down here, and the triage and treat referral. We've also had this second sheet, which just reminds us of this sort of stratification that we've developed, and a reminder of the management. If we move on to the low back pain, this is quite crowded, but what we've done here is we've reproduced the start back scoring system if you prefer to do it like this, which then gives you a score down at the bottom as it develops, and then you can work out the subscores and the management as a result. For those of you who prefer protocols, we've got this, which is the same start back. It opens this protocol. You say, yes, I want to continue. And then you go through it with your patients and ask them the questions real time. Has my pain spread down my legs? If I just click through these to give you an example, let's say moderately there. So it gives you a score. It says the score's 7, the sub-score's 5, therefore we need to do a referral. You can click here and get up the patient information leaflet to hand to them, because that'll be helpful. But then you say, yes, I want to create a referral document, and it'll go into a normal letter writing template and merge all that information into the physio referral along with anything you've populated in this box. As ever, it takes a bit of time, but hopefully won't be too long. There we go. So that then gives us all of this, and we'll actually we'll populate your text accordingly. So yeah, let's get rid of that. So again, there's the links to the information and the physio referrals and the spinal triage and treat. We've got a separate tab for more persistent and recurrent low back pain. We'll probably put some resources on here for chronic pain. And then we've developed this tab for urgent issues and referrals. So just a reminder of the cauda equina, red flags, and then some reminders of what we do with certain scenarios and the current referral pathways for that. So hopefully that's helpful. Lastly, we have set up 2 prescribing tabs. These are simple analgesia with the redded areas for obvious reasons, and then a second one more for the radicular pain with the nice guidance prescribing there, with again the increasingly controversial gabapentin and pregabalin in red, which I'm sure you don't need a reminder for. Okay, well, I hopefully that is helpful for you and just reinforces everything that we've talked about in the tutorial. So good luck. Please get in contact with myself, Christian Verinder, or Martin Longley if you have any queries or if you wanted any other training.